Good afternoon, everyone. My name is Professor Rob Saint, and I'm the Pro-Vice Chancellor for Research Strategy here at the University of Adelaide, and it's my great pleasure to welcome you here tonight. I'd first like to acknowledge the Kaurna people, the original custodians of the land on which all of the University of Adelaide's campuses at Thebarton, Roseworthy, the Waite and here at North Terrace are built. Now, as many of you already know, this is our wonderful Research Tuesday series of free public seminars presented by leading researchers here at the University of Adelaide. Tonight we turn our attention to reproductive health care. With any type of medical care, most of us assume or hope that there is sound evidence to determine the course of our treatment. Unfortunately, however, this is not always the case. And that is something that tonight's speaker is determined to change. Tonight we have with us Ben Mole, Professor of Obstetrics and Gynecology here at the University of Adelaide. Ben joined the University of Adelaide in 2014, coming from the Netherlands, where he worked as a gynecologist perinatologist and a senior researcher for over 10 years. He's now a research leader with our Robinson Research Institute, a collective of internationally renowned researchers in human reproduction, pregnancy and child health. Ben has been awarded a prestigious NHMRC, National Health and Medical Research Council Practitioner Fellowship, has co-authored over 600 peer-reviewed publications, and is a fantastic mentor to young researchers, having supervised over 70 PhD students.
Yeah, thank you, Rob, for this introduction. And thank you all for coming and sharing some thoughts, hopefully, on a topic that I am passionate about. Some disclosures: I have some commercial connections, but payments go to my institute, and people call me neither a politician nor a diplomat. And another conflict of interest is that I was born in 1965 in the Netherlands. And I was actually a home delivery, delivered after 42 weeks. So to current obstetric standards, I think that has been quite a risky situation, but I survived and I'm here. The issue I want to talk to you about tonight is healthcare and healthcare cost. So this is a picture of 3,000 medical treatments, normal medical treatments, evaluated in the United Kingdom for the evidence of effectiveness. And what you can see here is that actually only 1/3 of the interventions that are done have a sound, proven evidence-based, and we know for certain that they help our patients. Some things we actually know that they harm, but we still do them. And the big bulk, 50% of what we're doing, actually we don't know whether they're helping our patients. Now, who can call me the budget of healthcare in South Australia? Anybody who knows that? It's more or less than $1 billion? 10 billion? Less? I think somewhere, I think 8, I don't know exactly, 8, 9 billion. So call me one company with a budget of $8 billion where the CEO doesn't know whether half of the money actually is helping his clients. And that's the problem that we're facing in healthcare. Is this a unique story? No, it's not. I was chairing the guideline committee of the Society of Obstetrics and Gynecology in the Netherlands. And 45% of our recommendations were based on sound knowledge. And in 55% we made a recommendation actually on agreement or personal experience. Is this a new phenomenon? No, it's not. Professor George Pickering in 1949 in London said, before concluding that the change for better or for worse in the patient is due to the specific treatment employed, we must ascertain whether the result can be repeated a significant number of times in similar patients, whether the result was merely due to the natural history of the disease or whether it was due to some other factor which was necessarily associated with the therapeutic measure in question. And then he continues, this would seem to be the procedure to be expected of men with 6 years of scientific training behind them. But it has not been followed. Had it been done, we should have gained a fairly precise knowledge of the place of individual methods of therapy in disease, and our efficiency as doctors would have been enormously enhanced. Now you think it's a new statement, but the statement is 65 years old. And I think the problem is still there. Also in obstetrics, this is what I did today. I was supervising obstetrics in the Lyle McEwen Hospital. And actually there were forceps delivery. The forceps is introduced, it's said, in 1500. But actually if you go back, the Romans already used the forceps. So we go back 2,000 years. And innovation in the mode of delivery has been very, very limited. What is the reason for that? Very interesting question. I think it has to do with the tradition of medicine that is very much based on pathophysiologic reasoning and understanding process of physiology and disease. And this is Hippocrates teaching medicine more than 2,000 years ago. But it took actually a very long time until we started to use quantitative measures. And this is James Lunt, who was a doctor responsible for the health of sailors. And actually scurvy was a big problem in that time. And he was the first one who did an experiment, and he gave half of the boats that went out fresh fruit. And the other half I didn't give them. And then he noticed that scurvy did not occur in the boats with fresh fruit. So this was not a randomized trial, but it was the first kind of experiment where he used quantitative data to see what was actually effective or not. And then it takes a very long time until randomized clinical trials start to occur. This is an example of 1944, where in the United Kingdom there was a drug called Petalin that was supposed to help against the common cold. And actually there was an announcement in the newspaper that this new treatment was coming very soon. But then I think an extraordinary event occurred. It was the Health Council that then said, no, we're not going to introduce it. We're first going to test it. And they did a randomized study giving 600 people with a common cold Petalin and 600 people placebo. They registered it on forms that I think still fulfill modern standards today. And the result was that Petalin actually cured the cold. 1.6% cured, 13% cured, 33% cured. But surprisingly, in the control group, the cure rate was exactly the same. So the conclusion was, if you have the cold and you use Petalin, you get better, but if you don't use it, you get better too. Now you would expect that that is happening with medicine today all the time. But it is not, and I see Bill Hague, my colleague, who is sharing desks. I think he can confirm that we do many things that are not based on sound evidence. So an ideal model would be that if we have basic science and innovation, and we come with new treatments, that we test them actually when they enter the health system. And then we formulate them in a guideline, implement them, and measure whether we do good. And this should be a continuous circle, but I will discuss with you tonight that that is not as easy as we think. After 1944, and this is a slide for my field, it took an enormous long time actually to have these randomized trials occurring frequently. And currently there are published about 75 per year in my field, obstetrics. One example is progesterone, and this is a paper written by Paul Mees, who looks back at his career in medicine, and he was the one who did the big American study on progesterone to see whether it prevented preterm birth. But when he looks back, he first describes smaller studies done in the 50s and the 60s, and in that time you can reach the New England Journal of Medicine with a very small publication. And then it's actually Mark Kears, who is currently still professor at Flinders, who summarizes the available evidence and then concludes that progesterone potentially is effective in the prevention of preterm birth. And that work, he summarizes that in 1980, then results in a summary of the effectiveness of, or the description of the effectiveness of intervention in pregnancy and childbirth together with Murray Anken and Ian Chalmers. And that book has a foreword by Archie Cochrane. And Archie Cochrane says, 10 years ago I was looking at obstetrics and I was giving obstetrics the wooden spoon because it was probably the less evidence-based profession in the field. He said, but now we have this summary, we're probably improving. Archie Cochrane was in doubt between surgery, cardiology and psychiatry, but then he says obstetrics was really the worst field. And this is the meta-analysis that Marquez was doing, actually showing that progesterone potentially was effective in the prevention of preterm labor and preterm birth. And that paper then leads to a big American trial. I already mentioned Paul Mees, who was working at that time in a network. And he had together 20 centers where they randomized between progesterone and placebo in women with previous preterm birth. And that network then was an inspiration for many other people in the world, including myself, to organize studies together. So from the smaller studies that I previously showed, they started to do studies where actually a whole center was, a series of centers was working together, led by the NIH. And this, I was a resident at that time, it was mid-90s, it was early 2000s, was an inspiration also for myself and a couple of colleagues to do the same in the Netherlands. So if you want to evaluate healthcare and you let every professor organize one study, you get this kind of model. Everybody starts to call everybody. And the studies stay really small. So what we did in the Netherlands, we said we're going to sit together, we're going to make a list of studies that we want to do, and we plan, and that led to a much more efficient execution of the studies. So we started in 2003, 2004, first recruitment in 2005, and you can see that the number of recruited women went up, and it reached up to almost 6,000, and this was the moment I left to Australia, and it's going down, but still a considerable number of randomized women. And the number of studies actually grow. We started with 2-4 studies, and we're currently executing 30 studies each year. So the model went to this. This was myself as a PhD student, early 90s, to more this kind of situation where we do these studies much faster. And by the way, I took this picture when I was talking at the Dutch Society for Midwifery, which is kind of a good joke if you tell it to gynecologists. What happened to the studies is we did them in a relatively slow pace in the beginning, so they took 4 years. But by better calibration and organization, we went to studies that took 2 years, so we could answer more questions each year. And this is then what happens. This was the orange part that I showed you in the beginning. So these are questions actually where we don't know what to do. And by doing the study, you can actually divide them in things that are potentially effective and things that are ineffective and you should not do. So this really helps the healthcare system to improve, and you learn actually from the studies you do. Should the study result dictate in what we do? No, it should not. I want to stress that the results of studies should be used in what we call shared decision making. We inform the patient, and together, between the patient and the doctor, we decide what the best treatment is. So it's evidence-informed medicine instead of evidence-based medicine, and it's shared decision making. But if we don't have information to inform our patients, it's not a shared decision making, it will be shared gambling. So this is potentially the ideal picture, but we really need studies to inform us. What about the economic part of it? I think it's actually a no-brainer that we should do this. Each of the studies I showed cost per study, we did them in the Netherlands for 300,000–400,000 euros. And sometimes the benefit is nothing because you don't change practice. But sometimes the difference is also huge, because you learn from a particular study, change practice, and actually start to work safer. So if we added up the total of the first 8 studies we did in the Netherlands, then we spent just over 2 million euros. But the gain per year was 10 million euros. And that was only for information exchange in the Netherlands. Now realize also that those papers are published internationally and that Australia benefits from Dutch papers and the Netherlands benefits from Australian papers. Is it that obvious that we think that we know what we do? This is a list of Kathy Spong, who was leading the American network. She was in leading 4 big trials, where 2 actually confirmed that a treatment was effective. It resulted in a preventive therapy. And in 2 cases, the study resulted in stopping of a practice that was going on. This is a slide from my mentor, Patrick Bossuyt in the Netherlands, who is an epidemiologist. This is the randomized clinical trials he did in 12 years. And actually the large majority where doctors thought that what they were doing was effective turned out to be not effective. This is a slide from Jim Thornton in the United Kingdom, who has a similar list of trials where he thinks actually that they changed practice. Now remember what a clinical trial is. A clinical trial is just an experiment to assess the effectiveness of a treatment. And it creates 2 identical groups. One gets the treatment, one does not, and then we count the outcomes. It's actually that simple. And we should not do it all the time. So sometimes in medicine, it is very obvious what is the best treatment. Take, for example, a woman with a placenta previa. Then if you do a cesarean section, you will make her better, and you don't need a randomized study actually to show that. But if you have a woman with a twin pregnancy, for example, then vaginal delivery and C-section are much closer to each other, and you need a randomized clinical trial actually to show that difference. So we randomize to get rid of the factors that cause bias. Some examples that we are currently dealing with. This is a study that was done in Europe on women with ovarian carcinoma. Now that is a terrible disease. And if you get it, you can treat it, but it usually recurs and then it's very difficult to treat. So after primary treatment with surgery and chemotherapy, there is the question to every woman who has that disease, does the treatment recur? And it's the idea that if you measure a tumor marker, that you can identify the recurrence early and treat that. But that was actually never tested. So it was current practice to measure the tumor marker CA125, and when after the disease that came positive again, women get new therapy. Until some doctors said, we actually don't know whether that is good, because we don't know whether that's helping our patients. So they started to do a randomized study, where they measured CA125 in all the women who were under control after ovarian carcinoma. But when it increased again, they only unblinded it to half of the women. And the other half of the women didn't get to know that result. Now that randomized trial was very difficult to execute. It took more than 10 years because many people thought it was unethical. And actually some ethical committees did not approve the execution of that study. But when it was completed, it showed this result. This is the survival. And this is actually the group that gets the result early. And this is the group that gets the results delayed. There is no difference. So we are following women, we are treating them early, and it doesn't help them. And it's only the randomized clinical trial that learns us that. This is the number of women that get chemotherapy. And you see that in the early group, they get that very early. And does it harm them? Yes, it does. This is their quality of life. And what you can see is that the women who are monitored early have a early deterioration of their condition as compared to the controls. So we're actually looking at the treatment that is, everybody thinks it's helping women, but actually it is harming them and it's costing money. So this study was published 5 years ago. What happened with the results, you think? Is it applied in Australia or not? You know where I'm going. These are the current guidelines on the website. They're actually 10 years old. And the guidelines still recommend to measure CA125. I emailed some colleagues. This is a colleague in another state who says, yes, I know that study, but it's heavily criticized, so we still measure CA125. This is a colleague a bit more close by who said, yeah, I know that study, and based on that study, we stopped using measuring CA125. But then, when I asked some registers, they said, well, it depends on the clinician. Usually, they perform it. And actually, this morning, I was having coffee with a colleague who says, yes, I still measure CA125, not aware of the result of the study I showed you. Another example is, my field is also in women who cannot conceive easily. So then if that occurs, we use intrauterine insemination as a treatment to help them. And I was myself involved in a study in the Netherlands that compared that treatment as compared to expectant management. And we were doing that and thinking, well, maybe some women will conceive if we do expectant management. But to our surprise, after 6 months, there was actually no benefit whatsoever from IUI as compared to expectant management. And the expectant group did a bit better. If we looked at the same group after 3 years, there was no difference. So waiting with the treatment for another 6 months did not harm those women at all. And then we did this study only in a good prognosis group, women who had quite a good chance to conceive naturally. And if you look in a group with poor prognosis, then randomization is difficult, because you have to say to women who try to conceive for 2 or 3 years, wait another half year. But if you compare women who stop the treatment themselves to women who continue treatment, then actually there is no difference there also. And only when in vitro fertilization comes to the table, there is a difference from the treatment. So again, we are applying a treatment massively that actually is not helping the patients we care for. We compared then IUI to IVF, and also in that direct comparison that was published in BMG 2 months ago, there was actually no benefit from early IVF over IUI. So those early treatments are very debatable. Now this is information from a website from an Australian clinic today that actually encourages people, subfertile couples, to measure AMH, anti-Mullerian hormone, and that is supposed to indicate people with a poor ovarian prognosis and a poor prognosis for that reason. So a very similar case as CA125, and the study actually that should be done to evaluate has never been preferred today. So we are doing actually this test to see who we should treat early without knowing whether we do good. A last example, if women get pregnant, then preterm labor is a pressing problem. About 10% of the women actually have symptoms of preterm labor, and 5 to 7% deliver early. And if that occurs, we can treat those women with drugs. Atosiban is an intravenous drug, and nifedipine is another drug. One of the problems we have in pregnancy is that industry is not particularly interested in funding studies because the market is so small. So we use actually drugs from other areas, and nifedipine is used in cardiology widely. We did in the Netherlands a study where we compared nifedipine, this is used currently in Australia, to atosiban. It's registered for the indication, it's not available in Australia. And the poor outcome rate of the children was comparable, 14 versus 15%, no difference. But if we looked at the breakdown, then actually the perinatal death rate was much higher in the nifedipine group as versus the etosipam group. Now realize that together with Australia, many countries in the world are using nifedipine for tocolysis. And I think maybe the most concerning issue is that if I show this data to colleagues, then many colleagues are actually not concerned. But realize that this is a non-licensed drug for use in pregnancy that has never been tested for safety. And actually we have these findings that are, at least I think, non-reassuring. So I come back, I have a look at where we are with time. Any questions thus far? I come back to progesterone, the study I showed earlier done by Paul Mees. Because when he found with his network that progesterone was an effective treatment to prevent preterm birth in women with a previous preterm birth, many other indications showed up. And actually, many people started to do studies also to evaluate whether progesterone would be beneficial in women with, for example, a twin pregnancy. But those studies were all done uncoordinated. Obviously, the Americans were the first then, because they do the earlier result, also the first to publish that women with a twin pregnancy don't have any benefit from progesterone. But that was followed by a publication in The Lancet showing the same result, and then many publications from other countries came. And the question is obviously, globally, how many studies should we actually do to prove that a particular drug is not effective? And can't we coordinate that better? And you think this is a unique example, but it's not. Vitamins to prevent preeclampsia, 6 big networks, including Australia, did that studies, all finding that actually vitamins do not prevent preeclampsia. So we're in a situation actually that there is no coordination and planning in international research in doing that studies. That results in slow recruitment in trials, use of different outcomes, and an inadequate capacity of research. So it's a bit like this. Everybody is doing his own thing, not really collaborating. So we are working on a network, actually, where still people work in their own situation and do their own studies, but communicate much more in what they are doing. We have set it up with a group of trialists from around the world. This was in Geneva 4 years ago, and has actually resulted in groups around the world communicating with each other. We meet at international meetings, allowing obviously the communication, and that allows us to come a step further from the conventional meta-analysis, Cochrane reviews, to actually meetings where we sit together with the researchers and share the data of the trials we did together. This was a publication we did with a large group of people who are actually responsible for all the progesterone studies in women with a twin pregnancy, adding up all that data. And what was very interesting to see is that whereas from the individual studies everybody thought that progesterone would not be helpful, it turned out to be helpful in women with a twin pregnancy and a short cervix. And it resulted in a next step, because there was another potential intervention, pessary. I have some slides on that coming up, where actually we are going to work together with a group of researchers prospectively to collect data together. So this is a group coming together in Washington last year where we plan the studies we're going to do, which is, I think, a big improvement as to where we 10 years ago. Another example, this is sildenafil. It's, to some of you, better known as Viagra, which is thought maybe to improve the prognosis for children with poor placenta function. And the collaboration has led to the fact that we're going to do 5 studies in 5 countries separately, but we're going to collect and integrate the data afterwards. There's a change in sharing data. People were always a bit like, I have my own thing, etc. But I think there is a lot of common sense that we should share the data of the studies that we did. I go who thinks that it does make sense what I say here? So why is it not happening?
Politics.
Sorry?
Politics.
Politics. What is your definition of politics?
A good argument, I reckon.
A good argument.
People working against each other.
I go one layer deeper and then I stop. This is Eugène Sutorius, who is emeritus professor of law in the Netherlands. And he was writing a piece that is called Crime in the Operation Theatre. And the story is like this. His grandchild is coming over for the weekend with him. And on Friday afternoon, she sees her grandfather as a judge working. And he is convicting criminals, 4 years, 5 years, 6 years. And then his granddaughter comes home with him. And she's watching the television. And then she says, "Granddaddy, you have to convict those criminals too." And then he watches. And he says, "No, that are doctors." So the question to you is, what is the difference between a criminal putting a knife in somebody and a doctor putting a knife in somebody?
Consent.
Sorry?
Permission, consent.
Almost good. Consent?
The object of doing it.
No, that's not. The judge doesn't agree with that if you do it.
Informed consent.
Informed consent, very good. And the other one?
Or motive.
Sorry?
A motive, different motive.
Ah,
Not really.
the knowledge that you do good. So the interesting question is that the professor in law actually says that the doctor must know that he does good before he does it. And the big question, obviously, if we don't have that knowledge, who is actually responsible for that? As another argument, there's the limited resources. So if we give one treatment that is not effective to somebody, we cannot give it to somebody else who actually needs it. And with limited resources, that is a problem. I go over these to end up. I think another problem in medicine is that we all want to be this. We want to invent and we want to do discoveries, but maybe just the very simple solutions are needed. And maybe also we like religious aspect or being a magician rather than being a scientist. So I think what we need to do is we should realize that many doctors and maybe also patients are in a comfort zone, but I think here we can make a difference. And doing the big trials is actually not that easy, and I agree with you that politics play a big role, because actually doing the study is very simple. It's like doing the dishes. If everybody does his own part, it's quickly fixed. But then you get the politics that prevent that. So in summary, I think that if effectiveness of treatment is not obvious, we need systematic observations of large groups of patients that guide our clinical management. I think we should summarize that in clinical guidelines, and we need national and international collaboration in the planning of studies and the development of guidelines. So if you buy a car or a washing machine, you see this and you know what you buy. But if you go to the hospital, you don't see this, so you don't know whether what you get is actually helping you. And I think that is a strange thing. So this system could help us with that. And it could actually help us to reduce this. And that is, I think, crucially important, because we must realize that if we don't do it, we may not be able to provide the effective treatments to people that really need it. So I go back to my own birth. That was in 1965. But my parents married in 1956, and this is the announcement of their marriage. So it took 9 years to get me. And I am the oldest son. So my mother really, I think both my parents, but specifically my mother, had a difficult time with that. And one of the issues that occurred was that in 1964, a gynecologist said to my mother, "Oh, Mrs. Mole, your tubes are blocked. You should have told me immediately." And it's still a trauma for her. She's 83. And the question is, was that test actually effective? And I can tell you that we have done the study now, and we're going to present it in Esher this year, that shows that flushing the tube with oil is more effective than flushing the tube with water. It's that simple. But the big question to all of us, how is it possible that we are not capable of answering those simple questions? And we should realize that the judge is looking over our shoulder. So I think that we should do these studies, and if I show this slide, a day without randomization is a day without progress, I always stop talking. Thank you.
Thanks, Ben. That was fascinating and obviously extremely important. I'll open up for questions.
I just wonder whether there's an opportunity to invite WHO to be more involved beyond the capacity of our professional organisations. There's some politics behind it, but...
Yeah. My wife is sitting 10 seats left of you, so I should be careful if I announce my travel plans, but I think I have announced at home that I'm the next week in Europe. And on Monday, I'm in Geneva with WHO. And WHO is very, very interested in these type of initiatives. But WHO cannot do that if we don't bring the change here. They don't have the power and the facility and also the resources to do that. So I think they want to coordinate and inform people and encourage. But I think as a medical community, but also as a research community, should also bring that change.
I was reading that remarkably well peer-reviewed journal the other day called the Adelaide Advertiser. And they had an article on that was recently used, which had toxic levels of chrome in it. And perhaps the clinicians putting it in should have checked that the proper tests had been done, because the article alleged that adequate trials in humans hadn't been done before it was released on the market.
Mm-hmm.
So yes, the clinicians may have to have some responsibility, but there was a step before that in which it was licensed for use in Australia, and that was by the Therapeutics Good Administration. What role should they play in it?
I think obviously they have a formal role, but one of the problems that we see all the time is that a particular test or treatment is introduced for a particular indication based on good data. And then once the treatment is there, we start to use it for everybody. And I think it is almost impossible to get a government control on that, because you create an enormous bureaucracy. And traveling from the Netherlands to Australia, I can tell you that one of the problems this country has right now is already bureaucracy. So I think it's really who is a doctor here? 1, 2, 3, 4. I think it's really the responsibility of the medical profession. We have the choice between either regulate it ourselves or wait until society comes to us. But then the regulations will be very bureaucratic, I'm afraid. Is that an answer to your question?
Results is an important thing. So someone else has to do the same experiment and get the same result or confirm the result.
Yeah.
With this setup, does that mean that we're reducing the number of trials, or this mixed data analysis overcome that?
No, I agree with you. I was a bit puzzled where your answer or question was going, because my field is also reproduction. So, but the reproduction of research findings is necessary, but I think that we should do it in a planned way. And actually, the examples I showed you, there was no coordination in between. So everybody was doing their own study, trying to get the highest journal first, and that is not the optimal use of resources, I'm afraid.
Are we to assume that these attitudes apply across all branches of medicine?
Yes, I'm afraid so. That is for me a difficult question, because I still think sometimes about Archie Cochrane giving us the wooden spoon in obstetrics, and maybe all other fields of I don't know what's happening. All other fields of medicine have organized it themselves. But if I look a bit around the surgery, internal medicine, psychiatry, I think the issue or the problem is everywhere.
To what extent is the lack of research evidence, randomisation, the effect of drug companies, marketing their product and encouraging people to use it when it's not appropriate?
So the issue of the drug companies want to make money, and I think that's a problem, or it's a fact in our world, but it's also a problem that is their main driver. So if they can help people and still make money, they will do that. And probably making money goes better if they truly help people. But if they can make money and they cannot help people, they will still make money, I'm afraid. So, and actually one of the things I've been thinking about, and I left that out of this lecture, is truth. Because I think science is very much on knowing what is the truth. But I think the truth is much more subjective than we think it is. So in the way we design our experiments, the sample size, etc., we can very well influence actually the outcomes of our experiments. And I think that the industry, and I think there are data everywhere, that are doing that massively. Now you can complain about that, but it's a fact. So I think the reaction should be that we create a second network, actually, that is a counterpart to the commercial network. So the commercial network is already globalizing. All the companies we talk about, they work in multiple countries. And I think as a research community and as a medical community, we should do the same. And I think then you create a balance that probably will bring the best type of progress. Realize also that some of the examples I gave are not evaluated because there is no money in it. If there would be big money in the knowledge that oil would make you better pregnant than water if you do a tubal patency test, it would have not lasted from 1964 till now to get the answer. And I think actually that's a problem for society to answer that.
Hi. So at the beginning of the presentation, you cited a UK study that said that 51% of maybe interventions were of unknown effectiveness. I was just wondering, what is the definition of unknown effectiveness in those studies, and how good is that definition? And also, that study said 51%, but what do similar studies say?
Well, I showed you two examples. I also showed you the Dutch guidelines, which were an independent sample. And I think actually it is an underestimation. So I think effectiveness is the knowledge that you really improve the outcome for the people you care for. So in my field, that is more pregnancies in case of infertility, that is more healthy born babies for women who are pregnant, and that is more women cured from cancer, etc. So it's quite objective measure, but it should be outcomes that are relevant actually to patients. And that's one of the developments we're in actually, that patients, or should we call them clients or women or just fellow human beings, actually are involved in defining what are relevant outcomes. So there's a big change going on there.
Thank you. You touched on it before when you said some interventions, there just isn't money. It's not sexy to do research into some things. The thought came to me about the current health system and in South Australia, and we're having trouble with money. And how do you get, maybe it's more political, but how do you get people interested in doing the research into studies looking at whether to intervene or not intervene? So if you knew that, say, not as many women needed caesareans or something, that would obviously save money, but how do you get people interested in doing the research?
Well, I think the system we create should not be dependent on whether researchers are interested in that. I think those answers the question should be answered. So I think that we should change the way we fund at least a part of our research, the evaluative part, and just say we are going to evaluate that. And that's actually what, for example, the United Kingdom is doing. They're looking at the guideline and they define an unanswered question. And then there comes a call that says, what is the best research proposal to answer that particular question? And then you get, obviously, a good proposal for a relevant question. Now, who's involved in catching the NHMRC deadline next week? And still sitting here, typing again tonight, obviously. So is there any agenda to which knowledge gaps should be fulfilled? There's not. So there's just a big pot of money in Canberra, and then everybody came up with his ID. So I think that we should actually change the question and not ask ourselves who is interested in, but we just says, well, this particular question needs to be answered.
Well, thank you for those questions. They were terrific, and thank you very much for that rather sobering talk. I think we all want to wish you all the very best with what is something that could be revolutionary if it's done properly in terms of improving the way that we carry out our studies. And we have a very South Australian thank you for having presented your talk to us. And would you join me in thanking Professor Moll again? So I'd just like to finish by letting you know about our next Research Tuesday event. Just a fortnight away on March the 24th, we have our first inaugural lecture for the year. We'll hear from Professor Finna Larison with a fascinating presentation on pure mathematics and the profound influence it has on human progress. If you haven't yet registered to attend, please do. And thank you very much for coming tonight.